Good afternoon. Thank you for staying on so late at the end of a very long day. And for the next few minutes, we will cover an interesting topic under the title of rectal cancer staging. This will be our agenda for today. Rectal cancer is actually the 8th most common cancer worldwide and is no longer a disease of the elderly, with increased incidence in patients below 50 years. The burden is substantial, whether in terms of incidence or mortality. Rectal cancer is among the top 10 malignancies worldwide. So, what is our contribution as radiologists? Thanks to high-resolution MRI, we can assess tumor infiltration within the wall of the bowel, assess important anatomical landmarks that affect surgical techniques and invasion into surrounding pelvic organs. To appreciate and understand our role, let us touch the outline of management of rectal cancer. Current guidelines broadly divide patients into two categories: those managed by upfront surgical management and those who will go for neoadjuvant chemoradiotherapy. This distinction is based on tumor stage, and MRI is the modality of choice in rectal cancer staging, both for primary staging, which we will discuss today, and for response evaluation. MRI can confidently differentiate localized disease from locally advanced disease, which will be managed by neoadjuvant chemoradiotherapy and restaged by a second MRI. But before we dig deep into the details, it is worth mentioning that MRI is not a tool to diagnose rectal cancer, but it is a tool to stage pathologically proven rectal adenocarcinoma. First, we will talk about the MRI protocol and the main sequences we acquire. The most important sequence, which is considered the backbone of the protocol, is a high spatial resolution T2 weighted image in all three planes. No fat suppression is required. A small field of view and slice thickness of less than or equal to 3 millimeters is mandatory to ensure precise anatomical details. The first sequence is a sagittal T2, based on which we can identify the tumor, its longitudinal axis, and plan the axial images perpendicular to the long axis of the tumor. This is mandatory for staging. Eventually, we are left with 3 sets of T2 images: T2 sagittal, T2 axial oblique, and T2 coronal. Next, we acquire a wide field of view, T2 MRI, along the length of the pelvis from the aortic bifurcation to the sphincters. This allows evaluation of the lymph node stations. As regarding diffusion, the resolution of diffusion is inherently low, so extension of the depth of the tumor in primary baseline studies is not usually advised. However, the pivotal role of diffusion remains in the response assessment post-neoadjuvant therapy. However, in baseline studies, it can assess the presence and help in detection of EMVI and localization of tumors. Regarding gadolinium, it has not proved to be effective for rectal cancer staging and is not part of the routine protocol. So, to sum up, there are many technical issues and points of debate regarding MRI techniques. However, it's agreed upon that endorectal coil and fat saturation are not advised. Issues such as spasmolytics, endorectal filling, and bowel preparation remain gray zones and depend on individual institutional experience. As we look together at this case, we will appreciate that the difference in slice imaging actually has a major effect in diagnosis. We cannot diagnose infiltration of the mesorectal fat except at a low slice thickness. Similarly, in the first image here, there is no fat plane between the tumor margin and seminal vesicle. However, the second image shows clear demarcation between both. Surprisingly, this is actually the same patient, however, with axial images acquired at different axes. Now, let us shift gears to some of the important anatomical landmarks. Believe it or not, there is no standard definition of the rectum. Whether you talk to a surgeon, radiologist, or endoscopist, each has their own. So it's actually a struggle with more than 11 definitions. However, lately, radiologically, the sigmoid takeoff is the agreed preferred landmark. How do we define it? It is actually the junction between the mesorectum and the sigmoid mesocolon. And on sagittal images, it can be viewed as the point where the sigmoid sweeps away from the sacrum. Regarding the lower border, it's a routine practice to determine the lower border of the tumor and measure its distance from the margin of the anorectal junction and the anal verge. The anorectal junction marks the transition between the anal canal and the distal rectum, and radiologically it is represented by an imaginary line between the lower margin of the sacrum and pubic bone. The the anal canal is very important, and assessment of the sphincteric complex is a game changer in surgical approach and may leave the patient with a lifelong colostomy. Therefore, recognizing it is very important, and this is possible on T2 coronal images parallel to the sphincteric complex. Next, mesorectal fascia. It is a fibrous structure surrounding the rectum and mesorectal fat and represents the anticipated surgical resection margin. It is considered involved directly by the tumor or any of its components, such as irregular nodes or EMVI, within 1 millimeter. The anterior peritoneal reflection is the layer of visceral peritoneum that separates the rectal external and intraperitoneal parts. It appears as a V-shaped structure. Invasion into MRF and APR are therefore different and represent different stages of the disease. The relation of the rectum to both structures depends upon the level of the rectum we talk about. At the lower level, the mesorectal fascia completely encases the mesorectal compartment, and as we move upwards, the anterior peritoneal reflection covers the rectum anteriorly. Now, coming to the reporting process. Each MRI report should systemically address a set of questions that we will go through quickly. First, the tumor morphology. Every tumor can be described as annular, semi-annular, or polypoidal, where the site where the tumor is attached to the rectal wall is referred to as invasive margin. Regarding signal intensity, classically tumors exhibit T2 intermediate signal. However, the presence of a mucinous component will appear as T2 hyper-intense signal, and actually, imaging is superior to biopsies in detecting the presence of mucinous components, which may be present as isolated lakes within the substance of the tumor. Regarding axial involvement, it is described by the clock face axis. And longitudinal involvement, as we mentioned, is measured as the lower border of the tumor from the anorectal junction and anal verge. Regarding low-lying tumors, it's very important to delineate its relation to the surrounding sphincters, levator muscle, and puborectalis muscle sling. Going through the TNM staging quickly, starting with the T stage, as we agreed, it should be done on planes strictly perpendicular to the tumor. The T stage is determined by the depth of invasion of the tumor into the rectal wall. Differentiating T1 from T2 tumors is not usually possible on MRI. However, it is not of huge importance because eventually they're managed in the same way surgically. The important decision to take is whether this tumor is a T2 or T3 tumor, and sometimes this decision is quite difficult because this desmoplastic reaction, which may be associated with T2 disease, can appear as spicules beyond the outer border of the rectum. However, it appears of low signal and shows no diffusion restriction. In contrast to true tumor invasion in T3 disease, which appears as intermediate signal and exhibits diffusion restriction. We will also discuss EMVI, which is tumoral invasion into the venous structures beyond the muscularis propria, appearing as serpiginous extension. By definition, the presence of EMVI entails a category T3 tumor. Stages T1 and T2 have no potential for invading extramural vessels. An important pitfall is misinterpreting EMVI as an enlarged lymph node. However, this can be overcome by the multiplanar capability of MRI. Is it important to differentiate both? Well, EMVI is a marker of poor prognosis. However, mesorectal lymph nodes are removed along with the surgical resection. Quickly going over the lymph node stations, the rectum is classically drained by the superior rectal artery cranially towards the inferior mesenteric vessels. However, in tumors below the APR, an additional nodal stations known as the lateral nodal stations are visible. All the nodal stations can be assessed on rectal MRI. They're also classified into regional and non-regional lymph nodes. But remember, the presence of nodal metastasis in general implies a stage 3 disease and the need for intensified therapy. Regional nodes include mesorectal nodes, which are removed in the typical TNM surgery, internal iliac and obturator nodes. But it is worth mentioning that pathologically enlarged obturator and internal iliac lymph nodes need to be reported separately, as they will not be removed in the typical TME surgery and will require targeted radiotherapy or lymph node dissection. The criteria for lymph node staging are also based on which lymph nodes we talk about. Mesorectal lymph nodes depend upon size and morphology, whereas lateral lymph nodes depend only on size criteria. Finally, tumor deposits are defined by the COMET trial, which is still ongoing, as this continues to the main tumor along the path of a draining vessel, which usually shows EMVI and have irregular margin. Contrast these with lymph node metastases, which do not interrupt the course of vessels, although they may be adjacent and generally have a smooth border. Finally, MRI can help in detecting the poor prognostic factor in rectal cancer, such as low-lying tumors, mucinous adenocarcinoma, involvement of the mesorectal fascia, extramural vascular invasion, tumor deposits, and the presence of lateral pelvic lymph nodes. Finally, always remember, MRI is a sine qua non tool in the staging of rectal cancer. The first aspect is to standardize your protocol and follow a checklist to fulfill the reporting prerequisites. Thank you.
Thank